So as I mentioned, this meeting will be recorded today. If you're attending remotely, please make sure to mute yourself in the microphone. If you're having audio issues, please join us by phone. And again, please be sure to mute your phone as you're joining us. Also, feel free to rename yourself and with your pronouns. You can do that by clicking on the three little ellipses that are on the corner to support that. Please type your name and affiliation or in the chat with the organization that we want to move forward. Mark Tiba will be one of our co-hosts today, along with myself and Stacy Hudson, who I will let her introduce herself as we do some land acknowledgements. Stacy, take it away.
Good afternoon, everyone. My name is Stacy Hudson. I'm from the California Health Collaborative, and I am the training and engagement facilitator for the ACEs Aware Project and the ACEs Network of Care in Kings County. We want to start off by taking a moment to be intentional in acknowledging that no matter where we sit right now, we are on Indigenous land. For most of us, we are on the grounds of the Yokuts, a tribe who are native to Central California, and the Miwok, a Native American group indigenous to what is now Northern California. We gratefully acknowledge the Native peoples on whose ancestral homelands we gather, as well as the diverse and vibrant Native communities who make their home here today. As an organization, well, rather as two different organizations that center on social and environmental justice, we feel it is crucial to be informed on the past and ongoing consequences of colonialism. We encourage everyone to learn about the history of these lands and to support Indigenous resistance here and across California.
Great, thank you so much, Stacy, for that land acknowledgement and for your introduction. So as part of the work that we've been doing here in Kern County, we thought it appropriate to bring together partners who are similarly doing work across counties. The Kings County ACEs Aware Network of Care, with funding through the ACEs Aware funding, is a collaboration between the California Health Collaborative, Kings County Department of Public Health, Kings Partnership for Prevention, Kings United Way, Area Health, Adventist Health, EMT Associates, Family Healthcare Network, and First Five Kings County. As like them, First Five Kern is also working with a number of partners: Unite Us, CAP-K, Dignity Health, Omni, the Kern Children Network for Families, Resilient Kern, and the host of partners that you see on this screen. Without all of you and them, this work would not be possible. And so we want to take a second to acknowledge everyone on this call and our partners that couldn't be here today, who are really working day in and day out to really move the ACEs Aware initiative forward in our respective counties as we strive to serve our families and communities. Next slide. So this is the agenda for today. Really want to do welcome and introductions. If you haven't introduced yourself, please do so in the chat. I want to make sure that we all know who's here. We'll be doing an exercise through Mentimeter. We'll providing some context and context setting around ACEs and what that looks like for our respective counties here in Kern County and also in Kings County. And then we'll talk a little bit about training and attestation when we think about ACEs implementation and look at some clinical staffing models and what that looks like for our communities. And then we'll also talk about ACEs implementation, and then we'll end the session about 3:30. Throughout the chat, if you have, during the training, if you have questions, feel free to put them in the chat, and one of us will kind of respectfully answer or look at that as a point of clarification as we go through the presentation. Next slide. Okay, and I'll pass it over to Stacy to do a quick exercise.
So during our presentation today, as Hector mentioned, we're going to be requesting your participation for engagement using Mentimeter. If you are accessing this meeting on your computer, we recommend using your cell phone or active engagement. And please leave the screen open for continuous access, as we will be using Mentimeter again throughout the session. I'm going to share with you in the chat the website, and you can also access it through the link shared there to go directly to our first activity. In just one moment, I'm going to share my screen with that. Okay. Can everyone see the first question coming up? All right. So the first question was, have you taken the Becoming ACES Aware in California core training? Remember, you can access that Menti by going to menti.com. The code is 9049-8214. All right, look at that. So it looks like we do have some community members who have participated in that core training and some who have not. And that's perfectly okay. We're going to be learning about it today. Okay, let's go to the next question. Your next question is going to be, do you utilize the ACE screening tool in your practice? Okay, 5 seconds to answer. Okay, so some are using the tool. It looks like the same amount of people using the tool as those who've been trained. So that makes sense. It would be kind of difficult to start using that tool if you haven't had the training and are not comfortable with it. And our next question is, do you use the algorithm? This is the ACES and toxic stress risk algorithm. And we'll be showing you the ACES Aware website today so that you can see where you can access those tools and learn more about how to begin implementation. Okay, so right now it looks like no one is yet using the algorithm for assessing ACEs and toxic stress risk. And finally, we're asking, are you connected with a referral platform? And if you're not sure what a referral platform is, that is okay, because we're going to be also talking about that today. Five seconds. Okay, so a little bit of a mixed bag on that one. Awesome. I'm glad to hear it, and I'd be interested to hear from the community later on this afternoon about those platforms that you are currently using. Thank you guys so much for participating in that.
Great. Thank you so much, Stacey, for that activity. It really is an opportunity for us to see who's in the room and some of the tools that folks have been using. You know, so as many of you might be aware or might not be aware, the Californian Surgeon General has set a bold goal to cut adverse childhood experiences in half in one generation. And this effort is part of Governor Newsom's California for All initiative. And so as we think about what this work looks like for Kern County, Kings County, and other parts of the state, it's an opportunity for us to learn around how our communities can move forward the ACEs Aware initiative as we work together to create some synergy and really address the needs of communities across the state. Next slide. As we think about the adverse childhood experiences that are happening in our respective communities, in Kern County, we know that about 18% of all households have experienced 4 or more ACEs. This translates to about 48,000 households or about 145,000 individuals. Similarly, in Kings County, almost 1 in 4 individual households, have experienced a 4 or more ACE score, which translates to about 10,000 households or about 32,000 individuals. And more than 47% and respectively in each county have experienced between 1 or 2 ACE score. And so what does this mean when we think about how communities are impacted from birth to adulthood? Next slide. We know that if the more ACE scores, the higher your ACE scores, the higher health inequities that you're experiencing. So as a baby, things like developmental delays, sleep disruptions, failure to thrive are issues that come to fruition when you're a child if you have a high ACE score and experiencing toxic stress and trauma. When we look at both school-age children and adults, we see that pneumonia, asthma, other atopic diseases increase. As a young adult, things like STIs, substance abuse, and mental health disorders become more prevalent the more toxic stress someone's under and the more trauma that they've experienced. And as we think about adulthood, that translates into chronic diseases being more exacerbated within our lifetime. And things like anxiety, chronic pain, diabetes are issues that impact us as we experience higher ACE score. Next slide. The high cost of ACEs to California is about $112 billion, right? When we think about asthma, arthritis, COPD, depression, obesity, the number of health conditions that become issues for us cost the state of California that amount of money. Imagine what we could do with those resources if we were able to shift the conditions that mitigate toxic stress and ACEs within our communities. What would you or your community do with a portion of that $112 billion across the state? Next slide. And so when we think about, the risks that are associated with this, right, we have to think about the health conditions that our communities are facing. Kern County currently is ranked 53 out of 58 in California when it comes to health rankings. Our partners in Kings County are doing a little bit better with the ranking of 33 out of 58. But when we think about the associated risk and how they become higher with the higher the ACE score that you have, you see here the number of chronic diseases that are impacted the higher the ACE score that you have, right? Alzheimer's, suicide attempts, heart disease, cancer are exacerbated as the higher the ACE score that you have. Next slide. And so now I'll pass it over to Mark, who will talk a little bit about the pair of ACEs, right? Both adverse childhood experiences, but then the adverse community environments that impact our health and well-being.
Thanks, Hector. Hi, everybody. We hear a lot about adverse childhood experiences and how they affect individuals, families, and communities. But there's also an underlying set of conditions that can impact the interplay between what happens in the home and what happens in the community. And we call those the pair of ACEs: adverse childhood experiences and adverse community environments. And when we look at the 10 questions related to ACEs, we have another set of questions that are related to the community that can drastically impact families and their ability to access healthcare and to take advantage of opportunities in the community. Those relate to poverty, discrimination, racism, community disruption, as well as the economic factors of the lack of opportunity because education hasn't been fulfilled, the lack of economic mobility, the poor housing quality and affordability, as well as in the past, we've had experiences in our society of redlining, which has kept folks out of certain neighborhoods and not allowed them to create wealth, something that we're really looking at much more closely as we go forward. And then, of course, community violence that occurs. Those things have a drastic impact on children, especially if they're exposed to those things along with the adverse childhood experiences. So that combination is what we have been looking at in Kern County for several years, and Kings County the same. We're trying to take a whole person, whole community look at these issues and trying to make an impact through the opportunity that our ACEs Aware work is providing us. As part of that, next slide, please, Stacy. We have a pretty methodical approach that we're using thanks to the ACEs Aware work that's been done over the last couple of years across the state. One of those is to achieve certain milestones that allow us as an organization and as a collaboration to achieve our goals. Those include these 5 milestones. Conducting a readiness assessment. Are we ready to be ACEs aware, to be trauma informed? To define our clinical roles and tasks. Do we understand what it's going to take? To gather our resources and getting to know our network of care. We were asked if we're participating in a technology solution to achieve that, and we'll get into that a little bit further, but yes, we are in both counties. Milestone 4 is looking at the future, conducting financing and technology, considering financing and technology needs that will help support the work of becoming ACEs aware and spreading this message of resilience and hope, and reducing the level of toxic stress in our community. And then finally, the milestone 5, monitoring our results and evaluating whether or not we're achieving what we plan to do. Next slide, please. So as we look at those 5 different milestones, we want to focus for a moment on milestone 1, conducting a readiness assessment, which we've been involved for quite a while in both counties. And what that entails is looking at actionable milestones that healthcare organizations should consider and complete to fully engage with the trauma-informed network of care in the community. And provider milestones include, have we looked at our internal workings? Have we considered the interaction with the community? Are we providing a trauma-informed atmosphere as we provide services to our clients, to our patients, to our members? And so being very careful and taking each step carefully, these milestones will help us achieve our goal as we go forward. So what we're looking at is having people trained and using the ACE screening tool, that they've attested to that use online at the ACEs Aware website, that we're actually training our staff. We're looking at our presentation model, our acceptance model for our patients and staff and clients. Whether or not we're actually implementing the ACE screening tool and then feeding it into a decision-making tree, an algorithm, or a clinical workflow. For example, if many of our patients don't have many ACEs, they don't have more than 3, they may simply need some guidance and some tips on how to maintain that level of growth in their own environment. But if they're experiencing 4 or more, that may mean that they need additional services, whether they're medical services or community-based services like food or housing or transportation. And then working with other providers who are trauma-informed. In Kern County, we've spent the last 3-4 years training folks, and we're not the only organization doing it in Kern, and Kings is doing the same, training organizations in being trauma-informed. Adding to that the ACE screening approach with medical practitioners, we hope is going to make a difference, because it will cover those medical questions that Hector raised in previous slides, along with the community needs that are available but may not be accessible or easily accessible for a number of different reasons. And so we've created an engagement platform called the Kern Network Kern Connected Community Network, in order to provide a referral, an easily accessible referral tool that our partners can use. So that's a little bit of the overview around conducting a readiness assessment, milestone number 1. So I think I'm passing it on now to Stacy.
Thank you so much, Mark. Why should a clinic ensure that all providers and staff receive adequate training and set in place continuing education plans before beginning the screening patients for ACEs and implementing toxic stress treatment? We'd like to share this testimonial by Deirdre Bernard Pearl, MD. She's a pediatrician and medical director in Santa Rosa, California. I'm just gonna, real quick, I want to make sure to share my sound here. Here we go.
Now let's start with our first question for Dr. Bernard Pearl. Before you started ACE screening, what were some strategies or steps that you took to implement, and what were some of the lessons you learned from this process?
Before we started ACEs screening here at Pediatrics, we decided to do a pretty extensive training of all of our staff. Definitely wanted to train our medical providers and our nurses, but we also felt it was really important that the whole clinic understand this initiative, because the way we thought about it from the beginning is that the ACEs screening, it's really not like other screening questionnaires. It's kind of unique and it asks such personal information. We thought it would make a lot of sense if everyone understood why we were asking all of these very personal questions and kind of get everybody on the same page. We looked at it as kind of a shift in our culture, because we were really shifting the way we were approaching primary care. So the training involved everybody, and a really important part of the training, what worked really well, was that we introduced the science of ACEs so everybody could understand how extremely important someone's adverse childhood experiences are in terms of their health in the future. And then we distributed the questionnaire itself to everyone. We didn't ask everyone to complete it or share their personal information, but we did want everybody to experience thinking about all of those questions and what it might be like to answer that as a patient here in the clinic. One of the lessons learned was that ACEs affect, well, we kind of knew this to be true, but then when it actually happened this way, it was kind of a lesson that ACEs are very common and many of our staff members have experienced significant childhood trauma. So that was a lesson in the sense that it was, it helped us to be more sensitive, like thinking about our own traumatic past that we may have had, helped us feel more sensitive to our patients' experiences too. So that was one lesson, was to be more sensitive by experiencing the screening ourselves.
To follow up,
So what was your takeaway from this video? How do you think staff uptake of the screening themselves might influence how they conduct the screening with patients? You can share in the chat your responses, or you can feel free to unmute yourselves and share any thoughts you had after viewing this video. Thank you, Anna. She shared going through their own experience can bring empathy and understanding as they facilitate the tool with their patients. Yeah, that was definitely a major takeaway that Dr. Bernard Pearl had shared, isn't it? And Jana, is that how you say your name? Jana? I think it changes how we view the people we may help, in that it's not just our clients, customers who need help, but often we do too. Yeah, it's true. And what the doctor shared, that ACEs is incredibly common, is very true. And we're going to be experiencing that a little bit more here in just a little bit. So developing training recommendations to enhance screening efforts helps to move an organization towards a more trauma-informed approach to care. This video, as you guys saw, offered that provider's voice on the process of following a readiness assessment to ensure that training of staff prior to implementing screening policies and protocols across their practice. Dr. Bernard Pearl demonstrates that implementation of the ACE screening process is possible to do, and patients can have a positive uptake to the screening when it is introduced with an ACEs-aware and trauma-informed approach.
Now let's start with our first question for Dr. Bernard Pearl. Before you started...
Sorry, guys. Here we go. Okay, so what we'd like to do now is conduct an anonymous participant screening. We're going to be asking participants to provide their ACE and resiliency scores. We ask that you please take 5 minutes to complete the screening. I'm going to share it in the chat here. Just give me one moment. We realize that this screening is best done in a clinical setting, and that it can be difficult to do. Due to the prevalence of ACEs, we recognize that it could possibly be re-traumatizing for some of you here today. So keep in mind that this is voluntary. But we encourage you to show yourselves compassion and remember that ACEs is not destiny, and understand that facing ACEs in your own life or the lives of those you care for takes courage. But we do hope that this request empowers our network to know your own personal history of ACEs. Following your review, utilizing our Mentimeter, and I'll be sharing that in just a bit, we're going to be asking you to provide some anonymous responses to a few questions here. So I'm just going to give you guys a few minutes to look over that screening. We'll look over the resiliency questionnaire as well. And let me know if you have any trouble accessing that document that was shared in the chat. So if you're comfortable, and again, this is completely voluntary, please share your ACE score on that Mentimeter, and I'm going to share it again in the chat, access to our Mentimeter. I do want to just take us back to that realization that the doctor shared in that video, that ACEs was incredibly common among staff. It's really quite normal for a lot of people in the caring professions to go into those professions because of the childhood experiences that they've had, and because they want to make a difference in their communities and change those outcomes for the next generation. So don't be surprised if you're seeing high numbers in the community that's here today. And I would also like to encourage our participants, again, to show yourselves compassion. And if this is affecting you, please, if you need to step up away for a moment, or if you need to do a little body shaking or some deep breathing, by all means, do what feels best to you to help you regulate yourself. So as you guys can see, there is a high prevalence of ACEs in the room here today. And I want to thank everyone who participated for their courage in participating in this. We're going to be moving into asking you about your resilience now. So again, look at that resilience questionnaire that comes after that screening in the same document. And think about the things that allowed you to become the resilient person that you are today. So we're going to be asking you what your resilience score was as a child. And this can also be a bit difficult if you perhaps didn't have a lot of supports growing up. I just want to encourage you to continue with that courage that you are willing to share those experiences here today, and also encourage you that things change, right? We may not have had a lot of support growing up, but perhaps in our lives as adults, things have changed dramatically for us, or we've changed things for ourselves and our children. And this really helps us to understand that ACEs is just one part of our story, because the supports, the buffering relationships that we've had in our lives also play a major role in who we are and who we are becoming and who we are going to be for the children and individuals that we support and serve. I would like to just give a few more seconds in case some individuals would like to also share their resilience score here as a child. We're going to be asking you guys in the next question, how about now? How has this changed? Okay. So I know that there were only 6 of you that participated. I understand that this can be tough. So if you need to just not participate in this, it's okay. But I want to ask you now to think about how this has changed, how that resiliency has changed in your lives as adults. What is your score now? Okay. Thank you again, all of you, for participating in this activity. I know it was quite challenging and perhaps brought up some emotional things for you. So I want to just be so grateful to all of you for the courage that you showed today in participating. If we want to change individuals, organizations, communities, and systems, we need to talk about our ACEs and how they intertwine throughout our lives. At the individual level, Learning about ACEs and resilience helps us understand why we behave the way that we do, and that our coping behavior is normal. It's a normal response to abnormal circumstances. At the organizational level, staff and leaders can use knowledge of ACEs and toxic stress mitigation to create healing-centered work environments and programs in all sectors. At the community level, educating the public about ACEs and resilience can provide hope and foster the development of innovative ideas about how to support families, organizations, and communities. Understanding the interplay between positive and adverse experiences offers opportunities for engagement with all sectors. Communities can use this new lens to create mindful, healing-centered, research-informed approaches to prevent adversity and encourage connection and healing. At the system level, policymakers and leaders can use research about ACEs to find common ground across fields and to support policies that promote the understanding of ACEs and how adversity and positive experiences work together. Looking at the scores of the participants that engaged in this activity today, we know that many of us are impacted by ACEs, whether that is through our own personal experiences or the experiences of the ones that we love. Understanding your own score helps you to connect with compassion and respond with respect to meet the needs of your community. When we consider the resiliency factors in our lives, we realize our strengths and understand that there is hope. Utilizing that lens of resilience when we connect with individuals, children, and families helps us to shift the focus from what happened to you to what strengths do you bring to bear in the face of adversity. So, ACEs Aware recommends that all teams and all team members take a certified ACEs Aware core training. That was the training that we asked you about at the start. Reading the resource materials provided by ACEs Aware and create plans to receive continuing education and training on the science and health impacts of ACEs and toxic stress, as well as the principles of trauma-informed care. The Kings County ACEs Network of Care has developed a guideline for taking the Becoming ACEs Aware core training and have worked to provide repeated live and recorded clinical and non-clinical training presentations. Resources we hope that our communities and organization team members will utilize as continuing education to grow their understanding and knowledge about the science and health impacts of ACEs and toxic stress. I'll share with you guys our LearnWorlds link in case you are curious and would like to know more about that. We do provide all recordings from our past workshops and trainings, and you can access them on learnworlds.com. So the steps to training involve completing the Becoming ACEs Aware training, as I stated, and you can access that. I'm going to put that up in the chat as well. And in just a little bit, I'll be showing you how to navigate the ACEs Aware website. The second step is to self-attest to completing the certified ACEs Aware provider training. And then screen for ACEs using the PEARLS, which is the pediatric screener, or ACEs adult screener, and use the billing code G9920 if you're working with Medi-Cal patients, or G9919 for a score of 4 or more. Treat the patient and heal existing conditions. The fourth step is to refer patients exhibiting symptoms of toxic stress to toxic stress buffering resources. And that can either be resources that you provide within your own organization, or perhaps outside of your organization that is provided by other community organizations. And finally, implement continuous learning and quality improvement process to encourage development of best practices within each organization. This may include continuous education plans through accessing additional supplemental and core trainings, such as the ones that were provided on that LearnWorlds link that I shared with you. or going on to acesaware.com and utilizing their additional trainings. In order to qualify for Medi-Cal payment for qualified screenings, Medi-Cal providers must self-attest to having completed the training. We recommend that when completing the self-attest form, providers check the option to be included in a directory of Medi-Cal providers. This will help Medi-Cal patients find ACES-aware providers once you've been trained and are conducting those screenings using the attested directory. This can also help if there is a referral platform in place. It can help other organizations who may be making referrals to your practice. ACES Aware has also recently provided a two-part community-focused training, which introduces the science of ACEs and toxic stress to both clinical and non-clinical community-based organizations whose services may play key roles in addressing ACEs and toxic stress within their communities. You can find those on the ACES Aware website. In addition to resources provided by ACES Aware, there are numerous resources tailored to clinical and non-clinical participants through the Kings County ACEs Network of Care, as I shared just now. I'm going to go ahead and put those links again in the chat, just in case you want to explore them yourselves. Oh, I did not pick up those links for me. Hold on. Okay. You know what? I would like to be able to just email this to you guys because I don't want us to get off step here. Sorry about that. Somehow I managed to get myself out of the presentation. I appreciate all of you being patient with me in this moment right now. Okay. Here we go. So in the chat box, please provide a response to this question. What do you think the hurdles are for staff taking this core training? You know that when we ask the community, not everyone has taken it. So please share what any barriers you think may exist. I will put that question in the chat as well. And if you're comfortable unmuting yourself and sharing a response to that, that is also welcome. And on the opposite end, fear of what to do if your scores are high. And that is where understanding toxic stress buffering resources is really important, and that is within the training. Uncertainty about what they are getting themselves into, and do they really have to do this? So that also comes down to, in the training, it talks about the health impacts of ACEs, right? And understanding that by addressing it, we can prevent a lot of health issues. Time understanding what community resources are available, time and commitment. Yeah, that time and commitment is definitely a big challenge for a lot of medical providers. That core training is only about 2.5 to 3 hours long, and you can like take breaks and come back to it and finish pieces later. I did it myself, and given that I was kind of busy, I did parts of it one day and parts of it another day. And it really was quite helpful to understand the science behind it. And it also does talk quite a lot about trauma-informed care practices, which I think can alleviate some of those worries of what are you getting yourself into, and how do you meet those patients in those moments. Unknown information about the training, time commitment, cost, follow-up components, staff not understanding why they need the training. Yeah. And coming to events like this can allow opportunities for that kind of conversation. So if you have done the training, what are some of the things that have helped motivate staff to take training? And I really appreciate everyone who shared their feedback on those barriers, because it is essential for us to know that and to help move past those barriers. So if you are working in an organization that has seen success with staff uptaking this, may you please share with the community what allowed for that success? What motivated staff? And if you don't feel like you know the answer to this, that's okay. Right? Some people are personally motivated. And perhaps that is an area that needs to be addressed, of how to motivate people and get them on board with it. So there's a couple more questions I have about implementing, but given what we're hearing from the community, I'm not sure that we want to go that direction just yet. Sylvia, thank you for sharing. I took the training to better understand what it would be like for providers. I do not have any staff. I imagine they may have the same interest as me, and to better understand the relevance overall. And Mark shared, many people who learn about ACEs have an aha moment about root causes for people's actions and decisions. Thank you, Mark, for sharing that. I myself have definitely had those aha moments after having worked with children for many years in Head Start programs and special education, and aha, that's where that behavior came from. All right, I'm not going to be asking the implementation questions here because we know that people haven't yet started the screenings. So let's go ahead and move on. Oops, here we go. So the first stage provides direction to assess the clinical staff model. We understand that health systems vary widely in the types and numbers of staff members available. Some may have a doctor, 1 or 2 nurses, and a front desk staff. Others may have a fully integrated care team that includes a care coordinator, a social worker, a mental health professional, in addition to the primary care provider, nurses, and front desk staff. It is important to evaluate the availability of staff resources to aid patient screening and a warm handoff to care coordinators who can support the referral process. To support screening and a warm handoff to resources, a care coordinator's function within a primary care setting can be performed by individuals such as referral coordinators, care navigators, community health workers, social workers, peer support specialists, and behavioral health aides. More important than the title is the skill set of that individual that performs these functions. Ideally, this person is resourceful, compassionate, service-oriented, and understands mirrors the community they serve. Identifying resources that support toxic stress mitigation is an essential part of having a strong network. And that's where that referral platform can come into play. Knowing what resources are available to support social services are the second part of what makes a complete network of care. Identifying community partners. This is a really big challenge. I know we hear from a lot of community members. The primary care team is only one part of that trauma-informed network of care. Many resources that address toxic stress are based in the community, such as food banks, community-based mental health agencies, parenting resources, mindfulness programs, faith-based organizations, local parks, early childhood education. In order to establish trust between healthcare providers and community-based organizations, healthcare providers need to understand, value, and partner with local resources, not just refer to them. For families, it is also important to consider the primary care team of parents, caregivers of children at risk for toxic stress as part of that network of care. Parents need to be healthy and stable to facilitate buffering services for their children. A toolkit resource has been developed by the Kings County Network of Care, as I had mentioned before, which offers providers valuable action steps that can be incorporated within any organization to aid the understanding of clinical and organizational resources and how they offer supports to mitigate toxic stress. And I believe that, Mark, I'm not sure if you want to share on those types of resources that are being provided through you guys right now.
Yeah, thanks, Stacy. We are providing links to many resources. We're building up the knowledge base of our partners in Kern County and encouraging more providers to take the training and attest to that so that they can begin to participate in our referral network. And we'll be talking about what are the benefits that exist around that. But many of these principles are things that the state Department of Healthcare Services through the Surgeon General's office is really trying to encourage all counties to adopt so that we can really spread the message about the fact that we want to stop ACEs for half of ACEs in a generation, just stop it in its tracks. Thank you, Stacy.
Thank you, Mark. And I did share the link to the Kings County ACEs toolkit. You're welcome to explore that. It is an extensive document, so I know that sometimes opening something like that and go, oh, I don't have time to look at this. I would encourage you to just take it in pieces and just look at it bit by bit if you're willing. Connecting to a bi-directional referral system to support that follow through with a referral is key to success in this process. And I know that some of our participants had mentioned that concern of, knowing what the resources are in the community. The Kings Referral Exchange is a county-wide system here in Kings County that is currently in place to help clients get the assistance they need. And we're still in the process of bringing more organizations onto that referral exchange to make a more robust list of options for referrals. A case study on how the referral exchange system supports provider screening will be discussed later on in this presentation. However, our toolkit offers additional information on the referral exchange and the 211 resource as resources for care. All right. So provider training, attestation, implementation of ACE screening. These are things that we're going to show you right now on just a quick little video of how to navigate the ACEs Aware website. Now let's explore the ACEs website at acesaware.org. Now, if you're looking to get certified, you can go up to the corner right here on the right-hand side and click on Get Certified. This will take you directly to where you can get the ACEs core training. Click on Start Training. If you have not already been here, it will prompt you to enroll and create an account. I can look down here and just show you guys real quickly what it looks like when you start your training. There are 3 sections to the training, the first being an introductory video. Introductory cases is second, and then you can pick specific specialty case studies to complete that. And then your program evaluation. Once you've completed this, you'll want to, if you're a provider, you'll want to attest. You can go down to the home page of the training and click on Attest. Now, this attestation is for Medi-Cal providers, as we explained earlier. And you can consent to being added to a public list of Medi-Cal providers who self-attest when you're doing your attestation. In addition, the ACEs Aware website provides a lot of resources for both medical practitioners and community-based organizations working to address ACEs in their communities. One of the amazing opportunities here on this website are the stages for implementing the ACE screening. Each of these stages takes you through steps that can help you to effectively and efficiently begin screening, understanding the goals, and following the steps. Including implementing your program and building sustainability. You can learn more about the benefits of screening, trainings that are being made available through ACEs Aware, as well as the screening tools that are available. And this includes the PEARLS tools for different age groups in English, Spanish, and additional languages, as well as the ACEs questionnaire for adults in English, Spanish, and additional languages. You may also get information about billing and payment, the clinical team toolkit, and clinician directory. I hope you are able to take the time to explore this website fully, and you can always come back to it as additional information is being updated and provided consistently. So to encourage your action towards staff training, that ACEs Aware website, as you saw, has links to resources for all members of the primary care team and communities. While approaches for responding to ACEs and ACE associated health conditions, the toxic stress may differ by practice and setting. The website aggregates and shares additional learning opportunities, research practices, and experiences that advance the standard of care for ACEs and toxic stress. Now let's
Stacy, I do want to comment.
Absolutely.
I want everybody to be clear. You don't have to be a doctor or a nurse to take that training. It can take a couple of hours. It can take 3 or 4 hours, depending upon how you pace yourself. But having done it myself, and I'm not a doctor or a nurse or a social worker, it is a really good training. The case studies that are associated with it are really insightful, and they quiz you on how you understand things, but it allows you, they don't browbeat you. It allows you to really learn from it. And I encourage as many people as possible to take advantage of that, because it opens your eyes to a lot of things that the practitioners are dealing with. And as we are building our networks of care in Kings and Kern, we need all to be informed about the processes that are involved in creating an ACEs Aware network. Thanks, Stacy.
Thank you, Mark, for elaborating on that. Yes, I also took that, as you guys saw my my training on there, and I haven't finished all the case studies. I believe you only need 3 to complete it, but I've done about 5 of them so far, and I'm definitely interested in continuing with all the other case studies, because each of them presents just a different perspective from a different view of a patient, or even a clinician or a nurse or a other staff member that might have some difficult experiences with this ACE screening. We'd like to expand the role of clinical staff. Care coordinators such as community health workers play an integral role in assisting adults, children, and families in traversing the healthcare and social service system and overcoming barriers they may encounter. The tasks involved in the care coordination function can be incorporated into the job descriptions of a variety of staff in primary care clinics, not just care coordinators. They include maintaining and updating patient and family contact information and treatment plans, building and maintaining a resource database for social services, community-based organizations, and programs available to adults, children, and families, using the resource database to refer adults and children and families access to resources that may help them overcome social and economic barriers to health. Interfacing with the primary care team to help assess social needs in a culturally appropriate manner. Facilitating communication across all providers involved in caring for those individuals. For families, identifying a trauma-informed primary care provider for parents and caregivers for children at risk for toxic stress, so that parent and caretakers and have that physical and mental health need met for themselves so that they can meet their children's needs. Engaging and collaborating effectively with other community-based agencies, and following up to ensure that needs are met and providing additional support as necessary. And finally, closing the loop with the primary care team when resource needs are resolved or ongoing. We understand that not every clinic has the staffing resources to provide this level of team-based care. In these instances, there are resources in the community that may be able to share in the responsibility to care coordination, such as managed care plans, IPAs, and family resource centers. What does your staffing model look like if you are in a clinical setting? I know I just had a lot to say right there, so if you need time to process what I was talking about, that's fine. And I see a question in the chat. Is there a cost to get trained and use these resources? This is a free training. The ACEs core training is free. You can also, the resources on our Learn Worlds website are also free.
And you can get an certification, not as a medical provider, but just as someone who has been trained. The state does provide that to you as an individual. So there's encouragement that staffs, that programs can do that to build their understanding of ACEs and the way the system can function going forward. And I will add that the governor's budget has added millions of dollars for community health workers coming in this coming year. So we really look to see that this is a growing field. I know folks up at Sac State that are training new community health workers, and that's probably occurring all over the state today.
And Sylvia, you asked a question in the chat. Is that something that is new, the certification? I believe the certification has been an option since the ACEs core training was provided by ACEs Aware. What's new is that they created some additional trainings for the non-clinical individuals wanting to get trained. And that is also found on the ACEs Aware website through their additional trainings options. So, and that you can, there's an attestation process for that to get certified as well. So it's just a couple of different paths you can take depending on the roles that you play. You're not remembering the certification piece. So did you do the core training? And perhaps the prompt wasn't easy to find to.
Yes, I did. I did it a very long time ago when it was first unveiled. So yeah, thank you.
Okay. Yeah, well, maybe just return to the website and look for that. Just ask, in their little search bar, look for the certification. It could be that the website has changed because they keep updating it. So maybe they realized, it wasn't, people weren't really finding that certification button. And so maybe that changed over time, and who knows?
Feel free to email Hector or Stacy or me, and we can put you in touch with our liaison from ACEs Aware if you need that.
Yes, I'm going to put my email in the chat for you guys. And then another question I had for you all is, do you have staff that specialize in making referrals and negotiating responses to those referrals. So does if you're in a clinical setting, is that something that you guys already have in place? Because some clinical settings already have that. And if not, that's understandable as well, as this is new. So when we're talking about implementation, the principles of trauma-informed care include establishing trust, safety, and collaborative decision-making. ACE screening and the assessment of toxic stress risk and ACE-associated health conditions provides critical information about the risk of a patient experiencing toxic stress physiology. If screening identifies a risk of toxic stress and or potential for ACE-associated health conditions, after discussion with the patient or family, a referral to support services and interventions may be appropriate. The primary care team should also take action to address unmet basic needs. That includes food insecurity, housing instability, access to green space, and health condition management, such as addressing asthma, mental health needs, diabetes, etc. Whether a clinic has a built-in care team or refers out to existing resources to provide this support to patients, it is crucial that there is an established clinical workflow. And you can find more information about that workflow on the ACEs Aware website. The workflow should include the appropriate response and follow-up from the ACEs and toxic stress risk assessment algorithm, and options for internal and external referrals to provide patients with the appropriate buffering supports against toxic stress physiology. We showed you the steps for implementation found on acesaware.org. These steps provide you with the support and guidance to effectively approach this process. Now we will jump into the fifth part of our readiness assessment. Actually, did anybody have any questions before I jump into this next piece? You can always share it in the chat or unmute yourselves if you're feeling comfortable. It's a lot of information we're throwing your way, so I like to try to stop and give you space to ask questions or get clarification. Okay. So we're going to be talking about that fifth part of our readiness assessment, which covers implementing an ACE screening tool, response algorithm, and clinical workflow. So we'll be showing you those items. And here we'll offer a reminder to you to the use of the pediatric and adult screeners. So there are 3 versions of the pediatric ACE and related life events screener. That's the PEARLS tool based on age and reporter. So whether it's the parent who's reporting on it, or if it's an adolescent, the adolescent might be reporting themselves. The PEARLS includes an ACE screen in part 1, as well as questions on other adversities which may increase risk of toxic stress. And for a total of 17 to 19 questions, depending on the child's age. Only part 1 is used to calculate that child's ACE score. So there's the PEARLS child tool for ages 0 to 11 to be completed by a caregiver, the adolescent tool for ages 12 to 19 to be completed by the caregiver, or the PEARLS tool for ages 12 to 19 to be completed by the adolescent. Implementation of ACE screening early in life increases the likelihood of early detection. It also opens an opportunity for rapid response and referral systems that can quickly bring protective resources to bear when early life adversities are detected through the coordination of cross-sector expertise. And here is that adult screener. Respondents count the number of ACE categories on the screening tool that they or their child has experienced and indicate only the total score without identifying. That would be the de-identified. So they wouldn't be showing each item that they're saying yes to on that screener. They're just saying their final score. Los Angeles County doctors using the tool during the coronavirus pandemic say it has prompted patients to open up about housing, food, and job insecurity. One testimonial was that the real take-home message of screening parents for ACEs, says one doctor, is that that my partners who are doing this say they cannot imagine going back to the way things were. The amount of intimacy they have with their patients has increased. Their comfort level with this was much easier to come to than they expected. All of the clinic's pediatricians now do ACE screenings. So this tool was selected because of the rigorous research framework under which it was developed, and because it allows patients answers to be de-identified, meaning that respondents can disclose the total number of ACE categories, as I said, that apply rather than specifying which ones. According to early data from the large pediatric FQHC, randomization to a de-identified versus identified screen was associated with greater patient disclosure and comfort. Now that is to say, of course, that the identified screener may allow physicians to understand exactly what types of services are appropriate to mitigate toxic stress, depending on the types of adversities and traumas experienced by the patient. So that's something to consider when deciding which of those tools to use. A critical strategy for primary prevention of ACEs and toxic stress in the healthcare setting begins with the universal implementation of trauma-informed care, which improves care for all patients, regardless of whether they've had traumas or not, but especially for those with a history of adversity. While part of the purpose of the TIC, or trauma-informed framework, is to recognize and respond appropriately to the symptoms and consequences of adversity and trauma to support patient needs, it also promotes an important primary prevention framework as a universal protocol that presumes a potential history of ACEs for all patients. As we all learned during our activity, ACEs is truly incredibly common. Its principles help support a strengths-based and non-judgmental approach to toxic stress assessment and intervention, and prevent inadvertent re-traumatization of patients. Now, as I stated before, the ACEs core training on ACEs Aware, it embeds a lot of information about the trauma-informed approach within those case studies. So you'll be able to really get a clear picture of what that actually looks like during a screening process. Providers can also empathize, motivate, and empower patients or clients with active listening skills and motivational interviewing techniques, while safeguarding against potential re-traumatization and vicarious trauma. It is therefore beneficial for all patients, providers, and staff. Trauma-informed care recognizes and responds to the signs, symptoms, and potential consequences of trauma to support the health needs of patients who have experienced ACEs and other risk factors for toxic stress. The following key principles of trauma-informed care should serve as a guide for all healthcare providers and staff, and as well for community-based organizations. Adopting a trauma-informed approach is not accomplished through any single particular technique or checklist. It requires constant attention, caring awareness, sensitivity, and possibly a cultural change at an organizational level. Ongoing internal organizational assessment and quality improvement, as well as engagement with community stakeholders, will help to embed this approach, which can be augmented with organizational development and practice improvement. So this is a change that it takes time, and as I said, it can be a cultural shift, right? We're moving away from the judgmental perspective of why are people acting like that, what's wrong with them, to that thought of what happened to them and what strengths do they have. Does anyone have any questions about that or any comments regarding the trauma-informed approach?
Here at Public Health at Kern County, we have been trained in trauma-informed care, ACEs, I don't know, Mark, probably what, 3 or 4 years now? And we when we basically go into the home as public health nurses or home visitors as public health aides or health educator assistants, we can assess the home life, what's going on. And if there is a behavior going on in the home, then we can use the ACEs score. And then also, we also do the ASQ. So what's new to me is the pearls. So that's another thing that we could put into our toolkit as far as assessing pediatric patients into the home, and then talking to their parents as well. But we have been using ACEs, and we kind of get a feel for what's going on in the home. And then we collaborate with our mental health providers, their primary provider, even as so much as calling ahead to their doctor's office, letting them know what's going on in the home. Because lots of times family members or patients are not as forthcoming when they go into a doctor's office because, you know, they have that God complex and don't know how to talk to a doctor. But, you know, but once I think it's a good tool to have them bring their ACEs score into the office, kind of help them with the history when they do a physical into the doctor's office. Does that make sense?
Absolutely.
But as a public health nurse, we've been using this, Mark and First Five Kern, we've been implementing this in Kern County for a while now. But like I said, what's new for me is the pediatric portion. So that's something I'm going to take back to my team. But it's very important. This was addressed to me when I was the maternal child adolescent health coordinator many years ago. And we even have I even met Dr. Folletti at the state, and he introduced this. So this is something that, I mean, that was my aha moment back in 2014. So this is something we need to keep rolling along, and we keep getting more new staff. And then we having agencies, we had Kaiser was involved. We had Kaiser implemented that into their offices here in Kern County. And we just need to bring other agencies on board. But I think a lot of medical providers that I've run into already are aware of that, and they try to get the history out of their patients. So, you know, it's everybody just trying to provide good care to their patients. And I know I'm talking too much, but anyway, but we do use it here in Kern County. Kern County Public Health uses it when we see the need. Now that we have the pediatric or the pearls assessment, we can use that tool as well. So thank you.
Thank you for sharing.
Elaine,
Yes?
sorry, Stacy.
Go ahead,
Elaine, I
Mike.
just want to add, thank you for that. We have been building this. We've been calling it our three-legged stool now. And that is, in order to stand this up, we have to have this training that people have gone through. That's what we now call Resilient Kern.
Yes.
We have to have the mechanism to train more people on the medical side. And the new thing is the Kern Connected Community Network, using the Unite Us platform in order to smooth out the referrals, to make them easy, quick, and productive. And that's where the trust factor grows with patients whose doctors are using these. They get quick results. So it's come a long way, but as you said, we have a long way to go.
We have a
Thank
long
you.
way to go, but I think it would be great if you could get the Surgeon General to do a Zoom meeting with all of us.
Well, we're working on that. We have a conference coming up September 15th, and we've asked her to speak at it. So
Awesome. Great.
yeah.
I
Let you finish
appreciate,
up, Stacy.
Yeah, absolutely. And I appreciate what you shared, Elaine. Also, the ASQ is a great tool, or the ASQ SE, which looks at social emotional development as well. So that trauma-informed approach, it has a focus on language. After a screening has been implemented, it's important to support the discussion of the screening and offer statements that support the patient's needs. I would even say that you want to do some discussion before you implement it, because it can be kind of shocking for an individual if they've never heard about this before to be handed this screening with no information. And while the Becoming ACEs Aware training offers case studies on how to support patients with positive ACE scores, some other examples to note are these statements here. The algorithm discussed in the next slides offer additional guidance to be included within clinical protocols to support next steps after a patient has been identified with an ACE score. So this is that pediatric ACE screening clinical workflow. And these directed series of steps comprising the clinical process are performed by providers or ancillary staff and will help inform the process by which the ACE screening is utilized in a clinical setting. So a member of the primary care team administers the scores and ACE screen. Screenings can be administered by the primary care provider, nurses, or medical assistant. The primary care provider is the clinical lead on that team caring for the patient or family. So based on the screening results, the primary care provider informs the patient and family about the science of toxic stress, their relative risk based on the assessment, and how it could be impacting their health. The primary care provider educates the patient about buffering supports that can mitigate the negative effects of toxic stress response, including ACE-associated health conditions. The primary care provider may also opt to provide relational healing strategies, such as acknowledging and supporting strengths, reducing stigma, and other patient education in addition to social service referrals during the primary care visit. Depending on the severity of ACE-associated health conditions, such as cardiovascular disease or asthma, a referral to a specialist may be required. Under the leadership of primary care provider, the primary care team will develop a trauma-informed treatment plan using the screening and assessment results as one key source of information. The core plan includes details for individual patient coaching, self-care, and referrals to community resources. Once the screening tool has been utilized, the question arises, what do I do with that score, right? ACE screening involves assessing for the triad of adversity. That's the ACE score, clinical manifestations of toxic stress, and protective factors. The first two components show on the gray box to the left and are used in assessing clinical risk for toxic stress, and all three help to guide effective responses. So this is the ACE toxic stress risk assessment algorithm. Let me see if I can pull this link for you guys and put it right in the chat here for you. There you go. So that's for adults, and it'll help you assess whether a patient is at low, intermediate, or high risk of toxic stress physiology. The algorithm's toxic stress risk assessment is based on a combination of both the ACE score and the presence or absence of ACE-associated health conditions. So who in the room here is familiar with this algorithm? I think that when we asked you guys earlier, no one was yet utilizing it. Is anyone familiar with it? Yes, Mark, you're familiar with it. You've seen it before. Thank you, Sylvia. And I know that this group has not yet implemented the use of that algorithm. So again, I encourage you to visit that ACEs Aware website and look at those tools. When it comes to referrals for treatment, whether it's to psychologists, psychiatrists, social workers, one of our partners at Family Healthcare Network created a protocol to address this. So one, if ACE screening places patient in the high risk category, they establish an appointment offered by the provider with the Family Healthcare Network behavioral health provider. So they do that in-house. And if the patient accepts, then they select the behavioral health ACE visit type to schedule the appointment with that behavioral health professional. If the patient declines, there is documentation, patient declined behavioral health service, right? And then of course they do a warm handoff to that health educator or appointment made by that physician or provider The health educator will complete and prepare the form and completes the point care registration. Fourth, the health educator can do a warm handoff to community services, depending on what is needed for that patient. And 5, on an initial behavioral health ACE appointment with the behavioral health practitioner, there will be a review of the ACE screening tool, and relevant internal or external resources will be offered dependent upon services needed. And 6 external resources may include a referral to a place like Central Valley Regional Center, county mental health for psychiatric services, psychological testing, additional resources for synchronic or Visalia, or other external behavioral health resources are offered. So that's one organization, that how they created their workflow. It's just an example. Adverse childhood experiences are, they're preventable. They're a root cause of numerous costly health conditions, as we shared before, and social challenges. Identification of exposure to ACEs and other risk factors for toxic stress through universal and routine ACE screenings helps clinicians provide more effective, equitable, specific, and high-quality healthcare. It may also ultimately reduce healthcare costs. Toxic stress is treatable. A consensus of scientific data demonstrates that early detection and early intervention is associated with improved outcomes related to toxic stress. Preventing ACEs, like screening to assess risk for toxic stress, and effectively responding with evidence-based trauma-informed care in the healthcare setting and across sectors, can significantly improve the health and well-being of individuals and families for generations. ACE screening supports a provider's understanding of their patient's history and can lead to more informative decisions regarding their health promotion, prevention, and effective treatment of illnesses. A body of research shows that the negative outcomes associated with ACEs are preventable through early detection and prompt intervention. ACE screening allows for the detection of individuals at risk of toxic stress physiology by assessing for adversity, clinical manifestations of toxic stress, and protective factors. Universal rather than selective screening is important because the evidence shows that ACEs, as we saw, are prevalent across all populations, groups, regardless of demographics, and there is substantial individual variability in how toxic stress manifests clinically. ACE screening provides clinicians the opportunity to educate patients on the relationships between ACEs, toxic stress, and health, as well as evidence-based stress mitigation strategies to prevent and treat toxic stress. For patients at risk of developing toxic stress physiology and those who are currently experiencing ACE-associated health conditions, screening results provide information that support treatment plans. Screening helps clinicians and patients form stronger therapeutic relationships, and that's a really big deal when it comes to addressing these issues. ACE screening also provides a tool for conversation that can improve that patient's comfortability with their provider, the cornerstone of quality healthcare shown to result in better treatment plans and improved outcomes. Clinicians report that ACE screening has helped them develop a deeper and more trusting relationship with their patients, increasing their empathy for those patients and improving communication in general. Third, ACE screening can improve clinical decision-making and treatment of serious and difficult to treat health conditions, as explored earlier. Toxic stress is treatable, as I stated before. And there's a lot of data already available to provide on that. And when you guys are visiting that aceware.org, I encourage you to access the trauma-informed network of care roadmap, which provides information. It's an extensive document. It provides information on the health risks involved, and it also provides information on research-based toxic stress buffering resources and activities and experiences that promote health. An effective response to ACEs and toxic stress requires action on 3 levels: primary, secondary, and tertiary prevention, or prevention early recognition and early evidence-based intervention to break the intergenerational cycle of ACEs and toxic stress and improve outcomes at scale. Both the upstream or systems level factors and individual level treatment must be addressed. The healthcare setting offers a unique opportunity to help patients and families understand the impact of ACEs on health and to prevent and treat toxic stress. Of note, the clinical manifestations of toxic stress are currently best assessed by the presence of or absence of those ACE-associated health conditions. Efforts are underway to develop reliable clinical biomarkers that may inform diagnosis, prognostic precision, and therapeutic targets in identifying and intervening on toxic stress. Routine inquiry is an approach to understanding and responding to an individual's experiences of ACEs. It is a tool that can be built into practice with training, support, and supervision. Screening for ACEs and toxic stress and providing targeted evidence-based interventions for toxic stress can go a long way in addressing this issue in your communities. Okay. In addition, screening can also reduce long-term health costs. Medical necessities can be billable if the patients are on Medi-Cal. It can improve the efficacy and efficiency of healthcare. It can also be adaptable to individual modalities and provide for that unique practice needed for each individual. It's easy to use. And resources are readily available that serve as a guide and instructional support to group facilitators and individual practitioners. So this supports health promotion and prevention for illness. It helps clinical teams and patients form stronger therapeutic relationships, improves clinical decision-making and treatment, promotes an intergenerational cycle of health by reducing the transmission of ACEs and toxic stress. So some of the universal challenges of screening for ACEs, I mean, some of you guys mentioned these things when we asked you earlier, that lack of time. The screening tool has been identified to take less than 5 minutes to fill out. It's really the conversation that happens after that may take time. Provider best practice for screening implementation is during a patient's physical. Lack of provider comfort and fear of incorrect information. So this was another concern that you guys expressed when we asked you earlier what the barriers might be. Providing sufficient education, as mentioned before, will help facilitate provider comfort and utilization of appropriate skills to provide the needed information. Foundational training, such as the ACE core training and supplemental trainings that are offered, continuing education and support resources offer best practices for seamless information sharing and treatment planning. That includes attending sessions like this, where you can connect with other community members and share in your experiences and learn about the ways that different people are addressing barriers. Anticipatory guidance handouts specific to patient age are available within that ACEs Aware Provider Toolkit, and offers patient education tools on building resilience, nutrition and exercise, toxic stress, and self-regulation. Concerns regarding strength of referral system. That's a really big concern, and it was another one that was shared by participants today. Having a strong network of care and a bidirectional referral system, such as the Kings Referral Exchange that we have here in Kings County, utilizing that Unitas platform, can help ease concerns. Our Kings County ACEs Network of Care offers opportunities to access community resources, discuss resource needs, and receive support and strengthen referral demands. And we do that through our peer-to-peer sessions, our network of care sessions, and by providing those resources through the toolkit. Of course, there's that additional fear of clinic liability and increase in cases of mandated reporting. And that is an understandable fear. Mandated reporter laws make authorities respond to physical abuse and neglect. Part of ACE prevention is ensuring a community has an infrastructure to meet the basic needs of every child in the community. And And evidence-based outcomes show that resources such as maternal home visiting programs effectively prevent both emotional and physical neglect. They also help parents control any mental illnesses and substance abuse issues they may be suffering from, eliminating another source of ACEs. Increase in screening and helps saves lives and prevents neglect from starting. Questions about tools and scientific foundation come in. The tools provided by ACEs Aware have a solid foundation in evidence-based practices and can be reviewed to see where the references derive from. I would encourage you to also access the Roadmap for Resilience, which was produced by Dr. Nadine Burke-Harris and ACEs Aware, which goes even more deeply into the science of ACEs and resilience as well. Perception that ACEs are outside physician core function is another barrier. Understanding how toxic stress is the root cause of adverse health conditions helps us see why simply focusing on the symptom misses the root cause of condition or behavior. As providers, we must get to the root of what is causing the problem. If you've ever seen that TED Talks by Dr. Nadine Burke-Harris, she utilizes a story of a well, right? There's this, everyone's getting sick, right? And you can give dose after dose after dose of antibiotics, but people keep getting sick. You have to look in that well and see what is causing the sickness, right? Get to that root cause. Can you relate to any of the mentioned challenges? I know that a lot of these were mentioned earlier. And have you addressed these challenges in your organizations or communities? If so, please share with the community. Okay, I know I just gave you guys a lot of information again. I keep doing that. So I wanted to share a case study with you utilizing a referral exchange system. Redwood Pediatrics in Fortuna, California is an example of an independent small practice and rural health clinic that conducts ACE screenings despite not having a robust network of care for referrals yet. The clinical care team consists of 2 physicians, a pediatric nurse practitioner, a registered nurse, 2 medical assistants, a referral coordinator, a front desk staff member, and a bookkeeper. After a patient is screened, the ACE score is recorded in their EHR to inform the primary care provider that the child and family has a history of trauma and could be at risk of toxic stress. The pediatricians deliver healing strategies such as acknowledging and supporting strengths, reducing stigma, and other patient education. They partner with the referral coordinator in connecting their patients to external resources for the visit. Patients sign a release of information so patient information may be shared with outside organizations to link them to services. Community partners include Partnership Health Plan, Beacon Health Options, Humboldt First 5, and the Humboldt Network of Family Resource Centers. The providers at Redwood Pediatrics would benefit from bidirectional referrals, however. They currently rely on patient self-reporting to find out if patients and families successfully receive further services. To that end, the North Coast Health Improvement and Information Network is working to create a community resource directory and health information exchange funded by the county and community agencies. This process includes HNFRC, the Department of Health and Human Services, local hospitals, and the Open Door Community Health Center. Now I'd like to hand this over to Mark.
Thanks, Stacy. We also have a pilot that's going on in Kern County. One of our complex care pediatric providers is conducting her own work on this at Omni Healthcare, Family Healthcare. Her name is Dr. Anu Rao. And by the way, we're having a symposium next Wednesday morning. It's from 9 to 12:30. And if you email me, you can sign up for that. It's a free symposium, but you'll hear Dr. Rao share her story of being one practitioner with a small clinic, but serving medically vulnerable infants and children up to 21. And these are some of the results that she's found using the Unite Us platform. That's part of that three-legged stool I mentioned. What's great about this application is that it's very easy to make referrals and to track the referral, to find out who served that individual based on the referral that you provided. You get that feedback. And Dr. Rao will be sharing her experience with it. She calls it her virtual care coordinator. And what we find exciting about that is if we can get more providers to join in that as conducting a screening, which she does, and using that as a conversation to build trust, to build experience, to build treatment for her children, and to serve the family as a whole, providing them a referral for food assistance or housing or job assistance, things that they speak to when they discuss the challenges that the family is facing, then it's a win-win-win in regard to all of this. So we encourage you to explore more of the Kern Connected Community Network. We currently have over 70 organizations and over 120 services that are associated with the platform here in Kern County. And if you want to join up with that, again, you can email me or Hector and we can connect you with that information. The other thing I want to share is, well, how does this work? And what it does is it forms a closed loop referral system that provides the family the ability to give consent and use that consent to make referrals to benefit what the family has requested. You can go to the next slide, Stacy. Thank you. As we've signed up partners, we've trained them. We encourage them to use shared language. They're trained in how to use the technology, and they can choose to accept or not accept referrals. They can, if they're full, they can stop the referral process from coming to them. But what it does is it gives a quick pick list online for the provider using the system or other partners to use the system amongst themselves to create integrated, coordinated referrals and to get quick responses. People know this is a great opportunity. If you had asked me when I first started working in children and youth services that we'd be doing this kind of thing so seamlessly today, I would have laughed at you because we always went through the privacy issue. By providing consent, the individual gives permission to have the referrals made for them. And by the way, we also have a self-referral function with the Kern Connected Community Network now in Kern, so that an individual can make their own referral. But the key to this, and this is what is reflected in the governor's budget, in what managed care is trying to do, is to look at the whole person, the whole family, the whole community in many respects, by joining everybody together to work towards reducing by half the number of ACEs that are causing so many issues and get spread intergenerationally into further physical, mental health problems. So I'll pass it back to you, I believe, Stacy.
Thank you. And I also do want to mention that Unite Us is HIPAA compliant as well. So if there's those
Thank you.
concerns about confidentiality, that's something to keep in mind as well.
Great.
Organizational leaders may not be the first to learn about ACEs and their role in triggering the toxic stress response, but they play an important part in creating an environment that supports and sustains the adoption of ACE screening toxic stress treatment over the long term. Implementation research on a range of healthcare innovations shows leadership best supports the adoption of new clinical practices when they are when they're knowledgeable about the issues and intervention. Set an expectation that the innovation will be adopted, support staff through allocation of resources and rewards, preserve through setbacks or challenging circumstances that may come up. Being a champion in this work may entail making the case to clinic leadership. So if you're not a leader, that would mean that you're championing this in your organization by communicating with your leaders about the importance of this, of addressing ACEs. So understand your work environment. Who influences whom? Some people in your organization may be reluctant to implement ACE screening because they feel it may compete with and take resources away from other organizational priorities and programs. To determine how best to navigate the political dynamics of your organization, it can help to identify the essential decision makers and stakeholders that you need to get on board, such as the practice manager, medical director, and/or your CEOs. Align with leadership priorities. What are your organization's existing goals and priorities? They may include population health management initiatives. For example, mitigate chronic health issues, improve health equity, efforts to integrate medical and behavioral health, or working to be recognized as a patient-centered medical home. If ACE screening can support achieving at least one of your organization's strategic goals, you can make a stronger case for prioritizing ACE screening, integrating it into existing work, and requesting resources. How can ACE screening support existing goals and priorities? For example, screening for ACEs and treatment of toxic stress can be an essential practice for improving individual and population health by making healthcare more equitable. Sorry, getting a little dry. And third, anticipate and address potential barriers. What will leaders' concerns be? And some of you might already know what your leaders might be concerned about. Before you engage with leaders, think about any barriers, practical issues, and concerns that might come up during a discussion so that you are prepared to address them. Questions may include, will there be any required additional costs or resources? How will we integrate ACE screening into the existing clinical workflow? What impact will ACE screening have on our team? For example, clinician and staff time, burnout, secondary traumatic stress. Fourth, propose starting small. Does it have to be all or nothing? Implementing ACE screening and toxic stress treatment across your organization may seem like a tough sell, particularly given all of the other work going on. One way to begin moving forward is by reviewing your practice's experience and successfully implementing other clinical care changes and thinking about how to learn from and build on these approaches. Now, COVID-19 is one example of a barrier, right, that really did get in the way of this movement of addressing ACEs. But what has been realized is that people with high ACEs are far more likely to experience complications due to COVID because of the inflammation going on that is caused by toxic stress. So there's a case to be made for if we address ACEs, we can address other health issues. And of course, stay the course. What do you do if your leadership turns you down? Do not be discouraged if your initial attempt to secure buy-in from leaders is unsuccessful. Instead, work to address the concerns they bring up and suggest revisiting the conversation at a later date. In the meantime, continue to strategize how to align ACE screening and toxic stress treatment with your organization's priorities and consider starting or continuing a small pilot screening program. You and other ACE screening champions at your clinic can also continue to engage and educate leaders, clinical teams, and staff about the science of ACEs and toxic stress, as well as the importance of ACE screening and evidence-based responses. I'm going to hand this back over to Mark.
I want to share with you that we have, before we get away from that slide, we have formed a leadership committee. We have had one in Kern County for a few years now, and it's made up of about 15 to 20 leaders at all levels of our largest organizations. And that really is helping us set the tone and guiding the work that we're doing with the ACEs Aware project. Thank you, Stacy. So one of the things that we want to encourage you to do is go to numberstory.org, and there's a really cool video there that you can share with others. But we want you to join the movement, because if we're able to get as many people aboard, we can expedite this process and have change occur before our eyes. As we all learn more about ACEs, we become more trauma informed, we become more empathetic with those individuals around us, and we can even make sure that we're taking care of ourselves who are doing this hard work. So let's make our state of care ACEs aware. I love that. Next slide, please. There are many, many training resources. Stacy's done a fantastic job presenting those to us today. I really commend her for her work and her experience. This is a list of some of the things that you've seen. The ACEs Aware website is full of services and trainings and videos that you can participate in. They include the self-guided clinical supplemental training, the non-clinical training, and the readiness training for assessing readiness and building resilience in the clinical workforce. So we encourage you to take advantage of these when you receive the PowerPoint, because with that, you can share them with your team. You guys can do it together. You can do it individually. It's something that we all can benefit from as we go forward. Anything more on this slide, Stacy? The roadmap.
No, I'm just sharing some links with everybody for that.
Great.
Look at that roadmap for resilience. It is an extensive document. So again, don't be intimidated. Just take it pieces at a time. There is so much really good information there. I'm constantly revisiting it and going, oh yeah, this is really important. So it takes time to really digest all of this. So I encourage you to just check it out and take your time, come back to it whenever you can.
To our knowledge, as far as a state as large as California, this kind of integrated approach from the top down is really making a difference. But with the funding that's been made to many, many counties, including Kings and Kern, it's from the bottom up as well. So they're not imposing a specific way to do it necessarily. They really are looking for what works in our counties and how do we build on the collaborations that have occurred for many, many years, build them out and add this component, because it just strengthens our ability to serve people and serve them in a good way. Are we at the question phase? Yeah. What questions do you have? I know we've, as Stacy said, you've been filled with a lot of information. You feel free to open yourselves up to speak. And if you'd like to carry on a conversation, we can do that as well. Anybody?
A lot to digest.
Yeah, we really appreciate your patience through this, because it is a lot. So we have a survey that we would appreciate you filling out, right?
Yes.
It's at www.surveymonkey.com, and on your screen is the code to get into it and fill it out. We'd really appreciate that. We need your feedback. Two last things, as I mentioned, there is a symposium that we in Kern County are doing next Wednesday morning, the 28th. We encourage you to sign up for that. You can send an email to Hector or me, and we'll send you the registration link. We are also planning a face-to-face conference at the Marriott in downtown Bakersfield on September 15th. It's an all day. You'll be learning more about that. If you want to save the date, we encourage you to do it. And we're hoping that COVID doesn't get in the way, but we're planning a really great day. September 15th. It's another Wednesday.
I did put my email in the chat again, just in case you have, if maybe right now you can't think of questions, but something comes up later, you can feel free to email me and just send me your questions and I will do my best to answer them or direct you to the right resources to help you gain that knowledge.
Thank you so much, Stacy. You've done a fabulous job.
Thank you. Thank you for your partnership, Mark. And I want to thank everybody for attending today. I know this is it's a lot of information to take in and it can be a little bit heavy. So I really applaud everyone for sticking with it through this presentation with us.
I have to say the organization of this slide presentation is really going to be beneficial because it's distilled down so many things that could be spread across 4 or 5 different presentations. So if you're trying to make the case back at your agency, take advantage of this slide presentation, work it through, and you'll be able to answer any question that's thrown at you.
And again, if you guys wanted to learn, we have a lot of more in-depth information about all the different types of health and behavioral issues that are related to ACEs and toxic stress in some of our other trainings and network care sessions in Kings County. So if you're interested in learning more in depth about it, that's another avenue to take if you're feeling like reading those big documents might be too much, and maybe watching a workshop or training might be a little more digestible. That's an option for you as well.
Thank you all. Thanks for attending.
Okay, you guys have a great afternoon.
Thanks, Stacy. Talk to you soon.